smart healthcare and its applications. So today we will explore this new topic. So on the agenda I said is today's course is about diagnosing insomnia using sleep questionnaires. However, when I just try to organize my presentations, I think it's better to change the title to differential diagnosis of insomnia and sleep apnea using sleep questionnaires. And so that is the main topic we will talk about today. Okay, so before we jump to our data, I think it's worthy to introduce a little bit about sleep medicine, so you will have a better idea why we want to differentiating insomnia and sleep apnea just using questionnaires. So I think most people knows that sleep disturbance is actually very common, and most epidemiological survey indicates that around 50 to 35% of the adult population complain of sleep quality disturbance. And if you look into the statistic in Taiwan, and there was a number report in 2004 that the annual prescription of hypnotics in that year is around 65 million pills per year. And that number has increased to 313 million pills in 2014. And just imagine if you look up this information on the internet, we will find that in 2018, the number was around 900 million pills. So that is astonishing number of prescription amount in Taiwan regarding the hypnotics. So the reason that we prescribe so many hypnotics is really alarming, because it indicates that many people or many patients with sleep disturbance do not have appropriate assessment. So the doctors may just prescribe hypnotics whenever the patient complains about sleep disturbance. So that is the problem. And we know that the sleep disorders are very complex. They actually, if you look into the international classification of sleep disorders, we will find that there are many categories of different kinds of sleep disorders. But in general, we can summarize the different, there are major types of the sleep disorder here. So one of the major sleep disorder is insomnia, and of course there's a hypersomnia, which is the opposite of the insomnia. Insomnia indicates that it's a difficulty falling asleep and associated with other symptoms. I will introduce this later. And also there's a special disorder called narcolepsy, and also breathing related disorders, circadian rhythm, or like a non-REM or REM related sleep walking or sleep arousal disorders, or nightmare or restless leg syndrome, or even some medication or substance can induce sleep disorders. So there are many disorders, and we can imagine that when the patient comes to the clinics, you need to try to make a differential diagnosis between these different kinds of disorders, and most of the time it's very difficult to just differentiate these disorders based on the question and interview. So that's why in the sleep medicine we relied on recordings of physiological signals to differentiate this diagnosis. And in general, you can think that sleep disorders can be analyzed by different scales. For example, if you look into the day-night circadian rhythm scales, then you will you will identify some circadian rhythm disorders. For example, some young people may have sleep in the late night and wake up in the late morning. And older people may just sleep in the early night and wake up in the early morning. So that is the kind of delayed phase and advanced phase of circadian rhythm disorders. And if you look into the sleep period, you can also find in general there are three categories of the sleep disorder. One is from the psychological factors, which contains insomnia, substance-induced or sleep disorders, and physiological disorders like a sleep breathing disorder like sleep apnea, or neurological sleep-related disorders, which include restless leg syndrome, parasomnia, and narcolepsy. So, like I said, it's not very easy to just diagnose those sleep disorders based on the interview. So, in most hospitals, we will have this kind of examination, which we call polysomnograph examination, and the patient has to stay in the hospital for one night or sometimes even 2 nights, and to obtain objective assessments of sleep. So these objective assessments include recordings of physiological signals, just like the electroencephalogram, the electrooculogram, and also the measurement of the airflow from the nostril region, and also we will measure the oxygenation, electrocardiogram, which cannot be seen here, and also we will measure the body positions and also the movement of the chest and abdomen. So this measurement will give us an overview of the sleep status in real time, and also to quantify this, some diagnostic information based on these signals. So this is one of the example we will summarize in the polysomnograph report. So here you can see we simplified and also extract important information from the EEG, also from the other signals, and to make this graph. And this graph shows you that the horizontal axis is the sleep time. So, for example, this patient, he starts the recording at around 10 o'clock p.m. and he spent almost 3 hours to fall into sleep. So it's very long time. So this is definitely not normal. And also after sleep, you can observe there are frequent limb movement happens during the sleep. So this is a typical case of a periodical limb movement disorders, also combined with the so-called restless leg syndrome. Okay, so and also you can see other information here, including the sleep position. So for example, most of the time during the sleep, he maintained the supine positions, but before that, he just changed the position very frequently. And also we will measure the oxygenation, the saturation level, and also the heart rate. So these information can help us to diagnose different kinds of sleep disorders. But today, I would think I would just focus on insomnia and sleep apnea, because I will explain later why we will want to classify these two disorders just based on questionnaires. So if you look into the sleep EEG, which is recording the electrical activities of the brain wave, you will see that the EEG behave differently in different stages of the sleep. And for example, from the awake to drowsy to the stage 1, stage 2, and the deep sleep, also called the delta sleep, and also the REM, they have all different features and patterns that you can recognize. So for example, the EEG in the awake state, they usually have a low voltage but very fast rhythm. It's around it's a beta rhythm runs around 12 to 20 hertz per second. And also for example, if you close your eyes or you feel sleepy, then probably your brain will show the alpha wave, and it's a little bit slower than the beta, but it has a little bit higher voltage than the awake. And for the alpha waves, the frequency is around 8 to 12 hertz. And also, if you fall into sleep, then in the stage 1, we will observe an even slower wave, we call the theta wave. The theta wave is around 3 to 7 hertz, which is the 1 cycle per second. And in the stage 2, basically still the theta wave, but we will observe 2 different patterns, which one is the sleep spindle and the other is the K complex. And this is represent the increased activity of subcortical brain regions, try to homogenize the brain activities over the brain. So in the real deep stage of the sleep, you will observe the very low frequency of the brain wave, which we'll call the delta sleep. It's around 0.5 to 2 hertz, and you have observed a very high voltage of the slow wave. So this delta slope is kind of a deep sleep, and is related to the memory functions and also the recovery ability of the sleep. And intermittently, you will also observe a REM sleep, which is very similar to the awake and drowsy. So it's still the brain activity in this stage is still very active. And so you will have some vivid, very visual thought or imagings happen in your brain. So, but at the same time, your body will maintain a very restful state. So that's why in the REM sleep, we will not move. If you can move during the REM sleep, that is a problem. Okay, so that's a very brief overview of a sleep EEG. And based on this sleep EEG, then we can classify the whole night of sleep into different stages. And it's just like a driving. So you just put on your the clutch and the gears from the 1, 2, 3, 4, and it becomes slower and slower. Then you get into the restful state. Then around 1.5 hours, we will experience the first episode of the REM, and this REM will increase in the later half of the night. So you can see that basically in the first half of the night, you will have a more deep sleep than the later half of the night. But in opposite direction, you will have a more REM in the later half of the night compared to the first half of the night. So that is the typical sleep cycles in a normal adult. So regarding the insomnia, we know that insomnia is really a problem to fall into sleep. So and also you will have a frequent arousal and awakening for the patient with insomnia. So if you look into the Ph.D. polysomnograph recordings from the patient with insomnia, you will see that there are more episodes of arousal and wake in these patients compared to the good sleepers. So that is the one marker for insomnia. Okay, but in reality, we probably will not remember this brief arousal episode. We probably will remember when we wake for like 5 or 10 minutes, but it's very difficult to remember if we arouse just for 3 to 15 seconds or even 15 to 30 seconds. So So that's why for patients with insomnia, they often complain about poor sleep quality, but it's very difficult just asking them how was your sleep at night? Do you wake up very often? So if someone can remember the wake up time, that means it has been over like 15 or even 30 minutes. So that is uh, what we observe in a patient with insomnia. And there are different types of insomnia here. So patient may complain about difficulty initiating sleep. They may have difficulty in maintaining sleep. They may have early morning awakening. And many people also complain about unrefreshed sleep when they wake up. So these four symptoms are four major components of insomnia. And in the study published in Circulation in 2014, they related these four symptoms to mortality, and they found that patients with difficulty initiating sleep and also those with unrefreshed sleep, they have a higher association with the mortality. And this association is even higher when you consider the cardiovascular related mortality here. So difficulty initiating sleep is really a risk factor for the cardiovascular events and also the unrefreshed sleep. So insomnia is not just a symptom, it's related to the cardiovascular mortality and the risk. So that's why I need to emphasize that insomnia is not just a psychological complaint. It's really a problem we need to carefully look into the pathology. Okay, but it's true that if one has insomnia, then increase the risk of psychiatric disorders. So, for example, the patients with insomnia has a higher risk for major depression, anxiety disorders, and alcohol dependence or abuse, or even drug abuse and dependence. So that is quite a common sense about insomnia. And also in the patients with major depression, we will observe the different patterns about the sleep structures. So the upper panel show you the normal sleep stages in good sleepers. So as I said, in the normal case, usually we will have more slow wave sleep in the first half of the night and more REM sleep in the later half of the night. But this will be disturbed in those with major depression. So in the major depression, the REM is really just intermittently just intrude in our sleep. So that is why you can see that patient with depression, sometimes they will complain about the frequent dreams, and that is not uncommon, and actually they are related to objective assessment of the sleep. Okay, so now you know that the symptoms of insomnia may be related to other sleep disorders. So here I just give you a possible cause of these symptoms. For example, if someone has difficulty initiating sleep, you might be wondering that he may have anxiety, may have a depression, but we also need to differentiate if these symptoms represent a restless leg syndrome, which is a neurological sleep disorders that patient may have an urge to move his or her legs before they are going to sleep. So that is a subjective symptoms which is related to the movement, and that is sometimes is also related to the iron deficiency in anemia. So So that is one example that the difficulty initiating sleep is not just a psychiatric cause. They may have other neurological cause. Also, the unrefreshed sleep could be the indication or indicator of sleep apnea, because for the sleep apnea, you will have desaturation and oxygenation problem. So it will just cause frequent arousals and lead to the refreshed sleep in the early morning. And also for the difficulty maintaining sleep, they're also related to the anxiety, depression, and rest-like syndromes. And for early morning awakening, probably it's just more specific to the anxiety or depression. So based on these profiles, I already show you that actually we can still ask some questions to try to differentiate the different sleep disorders. And that is very important because it's very costly and to take lots of time to do the polysomnograph studies, because patient has to stay in the hospital for one night, and we will need a technician to accompany with the patient and to monitor his sleep during the night. So that is a very costly service in the hospital. And if we can do this at home, that would be very convenient for patient, also for the hospital. However, in the home sleep monitoring, usually this device is very simple. So we really need to know that if this patient has more about the sleep apnea or more about insomnia, then we can decide that he should undergo polysomnograph or undergo the home sleep monitoring. So that is the main rationale I want to introduce the class today. So for sleep apnea, probably the main symptoms reported by the family is that it's loud snoring. So patient may or may not know they have a loud snoring. Usually the symptom was reported by his partners, wife or husband or even child. So the prevalence rate of sleep apnea increases as we age. It is affect around 4% middle-aged men and 2% of the middle-aged woman, but the prevalence will increase up to 27 and 90% in the older populations. So the hallmarks of the sleep apnea, it is about the pause or gaps in breathing due to obstructions of the airway. So if someone was being complained about have loud snoring, usually we'll further ask if he or she has the pause of the snoring. Then that is one of the indicators of the obstruction of the airway. So 3 signs and symptoms about sleep apnea is, the first one is loud snoring. And the second one, because the patient may have frequent arousals, so he or she may have a daytime sleepiness and probably will just feel very sleepy during the transportation, during the commute route, and also patient in the long term may have an increased prevalence of hypertension. So these 3 symptoms, if you have 2 of them, then you should be very alert about the sleep apnea. And that is, the symptom is very important, but sometimes it's being overlooked because sleep apnea is not deadly at the first presence, but it can be associated with major medical conditions in the later life. So that is because it's very overlooked disorders, but in other ways, it's very easy to treat this problem. And the most simple way to treat this problem is use the so-called continuous positive airway pressure, which we call CPAP. So CPAP is just try to implement a positive airflow into the airway, so it will prevent this soft tissue from obstruct our airway. So that is a very easy principle to understand about the treatment of the sleep apnea. And also in sleep apnea, we need to differentiate whether this is obstructive sleep apnea or the central sleep apnea. The major difference between these two types is that about the sleep respiration drive. So in the obstructive case, the reason for obstruction is just like its name. It's because our oropharyngeal region was compressed by the soft tissue, and the airflow cannot be passed through this part of the airway. So you will observe the cessation of the airflow in this obstructive type of sleep apnea. But in that case, we still have the sleep drive. So we will observe our chest and abdomen still try to breathe, using our chest and abdomen to move our lungs and to try to breathe. So we observe some signals in chest and abdomen, but there's no signal in the nasal airway. And also in the contrast, the central apnea represent the loss of the respiration drive. So if there's no respiratory movement and there's no airflow, so that is one very typical example. And also for the mixed type, this combined with the obstructive but also the loss of the respiratory drive. So basically, we will consider the obstructive and mixed are the obstructive type of the sleep disorders. So this is one simple figure that show you the different degree of the obstruction in the airway. So in the normal breathing, there is no obstruction, and the air can flow very smoothly through the airway, and you will observe this kind of the flow curve. And in the very mild obstructions, you will observe some flow limitations. And in this case, sometimes it will induce, we call the respiratory effort related events, which will cause the arousal for these patients. So even a partial obstruction in the airway will cause the disruption in sleep quality. And also if there's a significant obstruction in the airway, then we will observe the hypopnea or even the apnea when the airway was completely obstructed. So that is we will count the frequency of the hypopnea and apnea for the whole night, and to calculate the number of the apnea, hypopnea episodes per hour. So typically, each episode will be considered a real episode if they last for longer than 10 seconds. So we'll count the number of apnea, hypopnea per hour to determine the severity. If the frequency is below 5 times per hour, then it is still normal. And if the apnea hypopnea index is around 5 to 15 times per hour, then it is mild sleep apnea. And if the number increases to between 15 and 30, then it is moderate sleep apnea. And if the number increases above the 30, then it is severe sleep apnea. So that is very easy to understand. And the key components here is the airflow and respiratory efforts, but usually we'll overlook the oxygenation status. So oxygen saturation is not reflected in the apnea-hypopnea index, but it's a very important information we need to evaluate a patient with sleep apnea. So like I said, one simple treatment about sleep apnea is using the positive airway pressure. Okay, so this is a very brief overview of sleep disorders, including insomnia and sleep apnea. And so the reason I want to give a lecture about sleep disorder is just try to give you a sense that it is not very straightforward to make a diagnosis of insomnia and sleep apnea. Usually we will use some questionnaires, but these questionnaires have some limitations. So maybe we can develop an AI model that can help us to differentiate these two disorders. So just let me give you some example of polysomnograph reports here. So this is a normal sleep. So you can see that this subject, so participant, he just falls into sleep within around 30 minutes, and he has some deep sleep, and the occurrence of the REM sleep is around 1.5 hours. It's pretty normal, and it's the period between different REM episodes is around 90 minutes. So it's a quite normal sleep, and he has no issues in desaturation, and the heart rate is quite normal. So this is a normal sleep. And this is a patient with primary insomnia. So as I said, you can see there are frequent awakening longer than 5 minutes, even 30 minutes during the whole night. And this patient has also some problems with the sleep apnea, but it's not very frequent, so it's not a big issue here. And the big issue here is that this patient has a very frequent awakening. So this awakening cannot be explained by the desaturation. So that's why we will diagnose this patient as a primary insomnia, because that sleep complaints cannot be explained by other physiological or psychological disorders. And this is a typical case of sleep apnea. So you can observe there's lots of desaturation during the night, but compared to the previous one, when you see lots of awakening longer than 5 or even 15 minutes, for the patient with sleep apnea, they usually have very brief awake periods. And this maybe just lasts only for 1 to 3 minutes, and patient will not remember he has so frequent brief awakening and arousals during the night. So that is one of the problems about sleep apnea, because if the patient are still young, they probably will feel okay about this, and the symptom will become significant until in the older age, when then the sleep quality is reduced to a certain degree. So sleep apnea is really a big issue. Then we should screen those with sleep apnea very accurately and also conveniently, so we can treat this problem in an appropriate way. Okay, so now we know that in a polysomnograph, we typically have different kind of signal here. EEG represent the brainwave assessment. The heart rate represent the autonomic functions assessment. And the respiration represent the sleep breathing disorders assessment. And also the leg movement assessment is for the neurological disorder like periodic limb movement disorders or rest-like syndrome. So these disorders, for example, insomnia, can be diagnosed with the EEG and the ECG. And also for the sleep breathing disorders can be assessed by the autonomic functions and of course by the respiratory data. And for the neurological disorders can be measured by EEG, ECG, and also the limb movement. So, if we can differentiate these disorders just based on questionnaires, for example, if an AI model can tell you this patient is likely to have insomnia, then he doesn't have to go to hospital. He can just receive the sleep home monitoring at his own bed. He doesn't have to go to hospital because patient with insomnia usually has difficulty falling into sleep. Then this complaint will be even worse when he goes to hospital. So that's why we have an AI model, can just ask some simple questions, and then we can differentiate the insomnia and the sleep breathing disorders. Then the patient do not have to undergo these whole things. He can just receive 1 or 2 signals monitoring. Okay, so this slide is in Chinese, but I want to tell you that in Taiwan, I think it's even worse in the United States. So in Taiwan, the hospital-based polysomnograph study, usually the waiting time is about from 3 months to half a year to even 1 year. So this is a very long waiting time. And I think it's also true in most of the Western countries that because in the hospital-based sleep examination is very accurate, but it's very it's not cost-effective. It's just we need to spend lots of space and time to do this kind of study. And however, the current device for home sleep monitoring usually are less accurate than PSG, but they are very good for the screening. So if we know the underlying cause of the sleep disturbance, then we can decide whether one should go to hospital or they should undergo home sleep monitoring. So that is the rationale I want to solve today. Okay, so as I emphasize, the smart health care is not just about the machine learning. We really need to implement the new workflow or new thoughts in the clinical practice so we can utilize the power of the AI. Okay, so for the sleep monitoring device, the current standard is that there are 4 categories. The type 1 is the hospital-based examination. Usually we have more than 14 channels of the physiological recordings. And the type 2 is a portable polysomnograph. It can be done at home, but usually we still need a technician to install the device before they bring the device back home. And for the type 3 and 4, usually will involve the fewer channels of the recordings, and that is usually that's why we want to divert the people from the class type 1 to the type 3 and 4 to reduce the workload in the hospital. Okay, so if you look into the market, then it has a very clear trend that the home sleep monitoring device has increased in recent years. And it's even true in this pandemic. So during the pandemic, the people do not want to go to hospital. They just, if they have sleep problems, they want to do this at home. So I believe this is an ongoing trend, not only in the Western country, but also true in the Asia Pacific regions. So that is one niche point that we need to overcome in the sleep medicine. So the challenges here is two questions. The first one is, how do we decide who undergoes hospital-based polysomnograph and who received home-based sleep monitoring? And in the clinics, we can only do this by interview. So an experienced sleep doctors can really decide that who needs the Ph.D. then the others probably just do not do anything, but just try to use other evaluating devices to do some examinations. But usually this kind of interview is not very accurate. So that's why we need an AI model to improve this accuracy. And so the second question is that if we have only questionnaires, can we diagnose patients of insomnia and sleep apnea just based on these questionnaires? And that is one challenge I want to show you today. And for the sleep quality assessments, one of the very famous questionnaire is called the Pittsburgh Sleep Quality Index. This paper was published in 1989, and then this paper has been cited more than 18,000 times. So that is a very significant amount of citations. And these questionnaires, we still follow the conclusion here of this paper is that a global PSQI score greater than 5 yielded a diagnostic sensitivity of 89.6% and specificity of 86.5% in distinguishing good and poor sleepers. So please note it here that these questionnaires, the original design is not to differentiate different type of sleep disorders. They just want to distinguish good and poor sleepers. So if you have a PSQI score larger than 5, then you will have a poor sleep quality. So that is very useful in clinical practice because we can use this questionnaire to screen those with poor sleep quality. But now we want to further extend our the utility of this questionnaire, that if we can use these PSQI results to differentiate insomnia or sleep apnea. So that is the challenge I want to let you know today. So if you look into the PSQI questionnaires, then you will get some insights about the sleep assessment. So in this questionnaire, we will ask, when have you usually gone to bed? Then how long has it taken you to fall asleep each night? And when have you usually gotten up in the morning? And how many hours of actual sleep do you get at night? So these 4 questions are basically the sleep latency and sleep efficiency. So that is quite important for the sleep quality. And also, the questionnaire will further ask some details about the sleep problems. For example, cannot get to sleep within 30 minutes, or wake up in the middle night or early morning, have to get up to use bathroom, cannot breathe comfortably, or cough or snore loudly, feel too cold, feel too hot, have bad dreams, have pain, and or other reasons. And also, the questionnaire will also ask about the medications, or for example, how often have someone taken medicine to help sleep, and also have any trouble staying awake during the daytime, for example, while driving, eating, or engaging in social activities, or if subjectively, how worse is the problem about the sleep, and will it is a problem to keep up enthusiasm to get things done. So that is overall the pictures of sleep assessment. Then you can have a sound sense that these questions can can roughly differentiate different kind of disorders. But if we have an AI model, then we can process these questionnaire results and give us an objective assessment of the differential diagnosis. So that is the purpose of our course today. So let me summarize the clinical workflow here. So the patients, when he or she comes to the clinic, we will do the sleep quality assessments. Then we will develop an AI model to differentiate if they have obstructive apnea or the primary insomnia. If the patient is likely to have primary insomnia, then we will do home-based sleep monitoring. Then otherwise, I think we will still arrange the hospital-based PSG, because usually the sleep apnea is better be assessed at the hospital to for the safety reasons. Okay, so this is the first part of our course, and I will give you a lecture about the sleep quality and sleep medicine, and the reason why we want to use questionnaires to differentiate insomnia and sleep apnea. So I hope you enjoy this lecture, and we will continue our workshop using the real world data. Okay, so take a rest, and we will show you workshop in a very short time.